right, well, today we're going to be talking about this new thing. I'm hearing a lot more than I have heard in the past 7 years of working in prostate cancer, or 9 years, the M0 space, or the non-metastatic castrate-resistant prostate cancer. So that's the same thing, and if so, what is it?
Yeah, it's come to people's attention because we didn't really have a treatment in the past, and now we do. So there's attention being placed to try and get the people that are in that space connected with a treatment that's available. And so what it is a situation where someone has had a previous treatment, surgery or radiation, and then they relapse, and then they go on Lupron or a hormone agent. And almost invariably, if people are treated with Lupron at an early stage, their PSA will become undetectable and continue that way for many years. But after a number of years, after about 10 years, about half of the men will have developed resistance to that treatment, and that's signaled by a rising PSA. The interesting thing about the M0 space is that all the scans that historically have been available, bone scans and CAT scans and MRIs, are unable to see any metastatic disease, or at least nothing outside the pelvic lymph nodes. So that status historically has just been watched, but now the M0 space can be treated with second-generation hormonal agents.
Okay. So if the scans can't pick up that there may be metastatic activity, does that mean there is like micro-metastatic activity, or it really is just localized to the prostate, or it could be either one?
It really, the consensus amongst experts is that it means that there is micrometastatic disease. So there are small metastases, but too tiny to be picked up with our previous scanning technology.
Previously, we've talked about the symptoms of prostate cancer, and that's kind of like a myth, actually. So because there's no metastatic activity, is there really any symptoms of non-metastatic disease?
No, only symptoms are associated with many times men, due to low testosterone levels, get tired and have hot flashes. But the disease itself is free of symptoms.
And so there's new drugs that have come out on the market for this new space, but it's been around. We just didn't have drugs, as you said, for it. So right now we have Xtandi, Nubeqa, and Erleada. And all of those, Xtandi's been used in the metastatic castrate-resistant space, and now they're using it in non-metastatic, correct?
Mm-hmm. Yeah.
Okay.
Yeah, so it's not surprising that it would be effective. Medicines that can be beneficial in very advanced metastatic disease oftentimes will even be more effective against earlier stage, smaller amounts of cancer.
Okay. And so with these drugs being in the non-metastatic space, does that push the sequencing out further so that a person can just have more kind of drugs in their tool belt and have more treatments down the line?
Well, I don't know about more treatments, but it certainly makes or delays the onset of metastasis for a couple of years usually. And so the previously good situation, men had a long time remission with Lupron, then can be extended even longer with these new medicines.
So with Erleada, Nubeqa, and Xtandi, I know we have Zytiga in the metastatic space. So how do they work differently from Zytiga?
So Zytiga is another effective second-generation hormonal agent, but Zytiga is different from the other three. Zytiga blocks the chemical synthesis of testosterone inside the cancer cell, whereas Nubeqa, Erleada, and Xtandi, they gum up the androgen receptor. The androgen receptor is like the switch that engages the genetic machinery of the cancer cell and causes it to grow. So these medicines get in there and they basically glue the switch in the off position.
So why do they call them first generation and second generation hormone therapies?
Well, all the first generation hormonal therapies were designed to stop testicular production in the testicles. Okay. So the blood levels of testosterone are very low. Prior to the advent of these new medicines, we thought that cancer cells had learned how to grow without testosterone. And that turned out to not be true. It turned out that the cancer cells were learning how to make their own testosterone internally inside the cancer cell. So when they designed second-generation hormonal agents to block either the on-off switch or the synthesis of testosterone in the cancer cell, then they're able to achieve remissions once again, even though the medicines like Lupron had stopped working.
Okay. Yeah. So with the first generation, I know that men oftentimes experience side effects like hot flashes and fatigue. Those Do those go for the second generation hormone therapies as well, and are they more intense?
They do go for the second generation hormonal therapies. They usually are not necessarily more intense. They do have some potential side effects that are a little different. Zytiga, for example, can cause irritation of the liver, and that needs to be monitored for. It can cause some changes in potassium levels. That needs to be monitored for. Xtandi has been associated with a little more intense fatigue in some cases, and Erleada has been shown to cause some rashes that you don't usually see with Lupron and those types of agents. But considering how much more potent and effective they are, the additional side effects seem to be pretty minor.
I know we've talked about sequencing in the past in my training with PCRI, and we talked about where Provenge fits in the sequencing. So now that we have Nubeqa and Erleada and Xtandi in this space, does that mean that people should be giving Provenge before? Is it going to be only approved for after those drugs? Where does it fit?
That's a good question, because the way the insurance landscape sets up, because Provenge is a very expensive drug, very few people can afford to buy it on their own. The insurance companies insist that the patients have detectable metastatic disease. So it turns out that detectable metastatic disease in the lymph nodes does qualify people for Provenge. And some of these patients that we're talking about in the M0 space do have detectable lymph nodes, and they would be eligible for Provenge. And in my judgment, most should get Provenge. But many other M0 patients don't have any detectable lymph nodes, and their insurance would not cover Provenge in that setting. And I expect that those men will have to postpone the use of Provenge until after these second-generation agents stop working, and 2-3 years down the line, at which point metastasis would start to appear.
Okay. Well, that is our latest episode of Ask a Prostate Oncologist. If you have questions you would like to ask Dr. Scholz in the future, you can go ahead and leave them in the comment section of this video and our team will pick them up. But we really appreciate your time. We thank you for being here. Don't forget to subscribe to our YouTube channel and visit our website, pcri.org, for more information.